We'll also have a lunch out in the lobby when we conclude, so stick around for that networking lunch. We're not allowed to bring the food in here, but we can hang out in the lobby and have sandwiches and catch up with one another. If we do have an emergency, we can evacuate through the lobby or a side door over here. And if anybody needs restroom facilities, they're through the lobby, just past the steps over there. So I'd like to begin with introductions. And I'm Kevin Dick. I'm the District Health Officer for the Washoe County Health District. And I'm going to introduce all of our speakers today. We'll run through the presentations. We'll probably run sometime between 12 to 12:30 by the time we get out for lunch. But we have Dr. John Packham here with us. It's a new introduction for me, introducing Dr. Packham, because he's now the Associate Dean of the Office of Statewide Initiatives at the UNR School of Medicine. We also have several different speakers from our local health departments. We have Nikki Aker, the Director of Carson City Health and Human Services, Heather Kerwin, who's been consulting for Carson City Health and Human Services, and we have Katrina Peters, who's our Director of Programs and Projects, that'll be speaking on Washoe County Health District and what we've been up to. Then we'll have Julia Peak, who's the Deputy Administrator of the Nevada Division of Public and Behavioral Health, and she'll be providing an update on public health advocacy and action. And then we're also honored today to have Senator Julia Ratty with us, and she'll be providing a lawmaker's perspective on policies for local health improvement. I'd mention also that Senator Ratty's a former member of the District Board of Health here in Washoe County. As she's the committee chair, interim committee on affordable housing. She's on the interim committee for health care, and she's also a member of a newly formed Regional Behavioral Health Policy Board. So with that, I will turn it over to Dr. Packham.
I'm going to have to look up this guy. I'm not looking in that way. Welcome. I'm John Packham. I'm with the UNR School of Medicine, and once again, it's my pleasure to present some of the highlights of the report that was made available and released by the foundation earlier today. It's this guy right here, and so I'll be hitting some of the highlights from that report. One of the things I wanted to state at the outset, this is a very different looking report than the foundation has presented in years past, and what you will see in there is their ongoing attention to social determinants of health, but also an explicit focus on health equity issues, so that when we talk about a county's ranking on any one measure, what the report takes a deeper dive into is the fact that if you look across race and racial and ethnic groups within any one county or within the state, you see enormous variation from top to bottom. Likewise, when you look at where counties in Nevada rank on something like childhood poverty or high school education rates, what they provide in there is a range of rates within the state of Nevada, so that, for example, on high school graduation, the difference between top and bottom in the U.S. might look like that, but the spread in Nevada might look something like that. So even our best performing county on a given metric like high school graduation or childhood poverty or social isolation is almost in some cases within the mid-range of national counties. And again, that's borne out in the report. And I really encourage you to take a look at that. And I'll close by encouraging you to also look at the Robert Wood Johnson website. I hope the direction that and I think the direction of the presentations that will follow me are going to go is we have no shortage of data. The data are very abundant. They're very clear in some respects. where counties rank haven't changed appreciably since we've been holding this event. That is, Douglas is always right up there at the top, and Mineral and Nye are always down there at the bottom. We know that, but it's important to, the report again highlights some of the factors and determinants driving those good or bad rankings as they were. Wanted to quickly mention some of our project partners and sponsors highlighted here, including the Nevada Public Health Association, the Nevada Public Health Institute that wrote the grant, as well as each of the local health authorities in the state and the State Health Division. Kevin's already covered that meeting. Here's one of the money slides. I actually, when I teach undergraduate policy, I devote an entire lecture to this slide. The class loves it when they have one slide for a class, but it's a really interesting and revealing slide in that they want to point out that yes, health in a community or health status in an individual is a function of clinical care, access to health care insurance, plenty of good availability of providers, whether it be primary care docs, dentists, mental health professionals, and so forth. But at the end of the day, it's driven by a number of factors outside the walls of clinical settings. That is to say, it's influenced heavily by behaviors which we know are associated with better or poorer health outcomes. It's influenced by social factors such as I mentioned earlier, educational attainment, high school graduation rates, children in poverty. One of the reasons that I think we've seen Washoe County fluctuate, and particularly on the outcomes where we've seen a drop in Washoe County, is higher levels of self-reported poor mental health days. It's kind of seen a rise there in Washoe and a couple of other counties. Well, you look a little bit deeper in the report, you'll also see that 1 out of 5 people in Washoe County are experiencing serious difficulties accessing quality housing, so that you kind of put the two together. And again, outside of healthcare, one of the things at least pointing to poor ranking with Washoe County is just difficulties finding housing. Again, regardless of whether you're employed, regardless of whether you are insured and so forth. This is, I think, in part something driving those poor health outcomes. So, with no further ado, drum roll please. Here are the latest rankings. What I've done this year as opposed to previous years is highlighted change over the previous year, so that when we presented this data last time, Pershing and Douglas were near the top, as was Lincoln and Elko, but you see a little bit of jockeying up and down. Story gaining several spots, Washoe dropping a little bit. I mentioned poor self-reported mental as well as physical health outcomes. If you look at the report is a function of a variety of different measures or metrics that are then weighted and weighted similarly across communities. Washoe is about average or middle of the pack on one of those, which is premature death metric that looks at estimated days of life lost before the age of 75. Don't ask me to go into the weeds any further than that. I'm not a statistician, but again, a great measure of health outcomes that are captured in these particular rankings. I had the lovely pleasure of going down to Nye County and telling them they were 17th prior to this meeting, and now I get to tell them 16th, but it's only because Esmeralda is excluded from the rankings this year due to low data, so I'll pass on that mixed message. It's some future date soon. But again, I think one of the things I'd want to highlight on that is the way that this set of ranking looks similar to what we presented on outcomes when we met a year ago. And this is the map. They provide maps in there as well. The lighter shaded counties, better on rankings, the darker shade of green, the poorer the health outcomes there. Interesting to kind of see the contiguous or connected counties there on the very end of the spectrum, but those have been shaded green for, again, as long as we've been doing that. And they include well, Esmeralda is not included this year, but Mineral, Nye, and White Pine. Let's look at the other part of that Robert Wood Johnson diagram that I mentioned earlier, and that is factors driving health. And again, this is a composite ranking based on a variety of measures of health behaviors, social and economic factors, clinical care as well. So I think what you kind of see rolling through these rankings is a number of counties that just continue to face persistent barriers in finding a primary care doc, accessing a mental health professional, or even finding a dentist. But I think what stands out in this one much more than the previous slide is all of the zeros, and that is basically no change in the ranking over time when we look at this year's ranking versus previous years. And then the color-coded map. This one is not a complete overlay. I think there's some a little bit of disconnect between rankings on factors and outcomes, but again, point out that what they're trying to highlight is today's health is influenced by upstream factors that are kind of captured in the inventory of health factors driving health outcomes. Now, take a deep breath and squint at this slide. A lot of information on this, but what I'd been presenting up to this point were the county rankings, and I've just pulled out a subset of those counties in northern Nevada and looking at, so I presented earlier the bolded lines, both health outcomes and health factors are a county's rankings, but if you kind of look and take a deeper dive within that set of rankings, you see that in a county like Douglas, okay, all single digits, regardless of whether you're looking at clinical factors driving health outcomes, social determinants, physical environment, and so forth, a lot of continuity versus, say, a county like Lyon County that's actively now through a relatively recently established Board of Health looking at a wide range of factors. And again, at the risk of pointing out the obvious, this type of analysis, the data provided in this year's new reports are really valuable for those local boards of health, for local policymakers in providing some direction on where they can target their efforts. I recently presented findings like this in Mineral County, and actually where they did well was on clinical outcomes, and urged them to focus more attention in specific areas indicated by the report. They'll get a data refresh with the new report, but again, targeting public policy efforts and interventions kind of start with this more granular data that's also contained in the county rankings data. One of the things I wanted to close with, and I didn't include it in a slide, but it was in this week's edition of the Journal of the American Medical Association. They have a wonderful national snapshot of prevalence rates for alcohol-related mortality, substance abuse-related mortality, self-harm, and so forth. And there's one that just gives me the chills in there. It's a map on mortality related to self-harm, and they have this continuum of blue and green, good colors, and red and dark red on that end, and every county in Nevada is shaded in red in that. And so when we talk about rankings from top to bottom on any metric, I think I would close by just saying be very mindful that, on some measures, it doesn't matter what county you are in Nevada. You are facing difficulties accessing mental health, as in that case the data suggested, as well as determinants in the social environment driving poor mental health outcomes. We'll close by just saying that all of that information, including the reports, including the data backup, definitions of metrics, and so forth, is contained in that county rankings website. And if you're struggling with insomnia tonight, you could spend hours and maybe hopefully go to sleep at some point by taking a closer look at that data. Thank you. I'm going to have our next presenters come up, Nikki and Heather, who are going to lead off our discussion of local efforts to improve community health. And welcome. Take it away.
Thank you.
Get out of your way.
Okay. Good morning. I'm Nikki, the Director of Carson City Health and Human Services, and we are talking about our community health improvement efforts. So we have, in 2017, we finished our second community health needs assessment, and I just want to thank Valerie Quape here. She was very instrumental in getting that done. And then right now, we are working on our community health improvement plan, and Heather Kerwin is helping us with that, so she'll be presenting information about our community health needs assessment and then where we're at with our community health improvement plan. So these two documents and efforts are big pieces of public health accreditation, of which we were accredited in May of 2016. And some exciting news for Nevada is we've got all the other two health departments that are well on their way too. So we will have a lot of all of our health departments accredited in Nevada, which is pretty exciting. So if Heather wants to come on up and she can present the information. Here's the clicker.
All right, thank you. And again, kudos to Valerie for doing the work on the assessment. It's a big project, as I know, so presenting another community member's hard work. But I'll do my best. So for those of you who are not as familiar with community health needs assessments, they help tell a story about population or community health of a geographically defined area. And while this is the Carson City Health and Human Services, there are certain areas of health which they do have purview over, which is known as the Quad County area. It does include Douglas, Story, and Lyon. And so throughout the assessment, there are some data pieces that do cover more that Quad County, although it is entitled the Carson City Community Health Needs Assessment. Which way do I point this one? Okay. All right. So I'm not going to run through the contents. I have slides on each of these, but this just shows you kind of the breadth of information and all the different moving parts of the community health needs assessment in general. And the first one has to do with the community. This is more the primary data. So this is the community survey assessment findings. Carson City is fortunate to have two nonprofit hospitals who are also conducting community health needs assessments. And so they partnered with them to utilize their survey data. So they had perspectives from two different surveys from both nonprofit hospitals that were conducting their own assessments around the same time. And the three major common areas that were found between the two overlay of those surveys were the access to healthcare services, reinforcing data and the results that we see from the county health rankings, as well as substance use and the safety, which involve both injury prevention as well as more that crime and violent related behaviors. And then I just wanted to highlight a few of the areas that were strengths as far as the secondary data goes, and so this is more of that statistically reliable, generalizable health data that we're used to combing through. And some of these areas include the food environment, the commute times, vaccination rates among adults for 65 years and older, and then some of those infectious disease, very low, less than 5 cases of syphilis, tuberculosis, measles, mumps, rubella, and then alcohol-related motor vehicle accidents. This is one that I like to point out because Carson is doing well at 24.7% of fatal motor vehicle accidents. And while that might sound high, most of the state and many of our other counties are much higher than that. So still a work in progress, but one of the ones I like to highlight. And then the early colorectal cancer screening diagnosis. Areas for improvement do include poverty rates, violent crime, food insecurity, high school graduation rates, and you'll see those are a lot of those socioeconomic, with the exception of violent crime, those socioeconomic factors, as well as tobacco, illicit drug use, so more the substance-related, obesity, which is an area that many of our counties, Nevada historically ranks a little bit lower than other states across the nation, but just as a nation in general, an area for improvement. Women who receive prenatal care within that first trimester, and teen pregnancy rates. One of the other assessments that is conducted, was conducted for the purpose of the Carson City Health Needs Assessment, is what's called a local public health system assessment. And this really looks at, if some of you are familiar with that colored wheel with the 10 major focus areas of public health, this looked at those focus areas and identified which ones that Carson City Health and Human Services really has strength in and which are areas for improvement. And so just taking the top 3 out of those, more the infectious disease side, the diagnosis and investigating illness, as well as emergency response with emergency preparedness programs, and development of policies and plans, as well as review and improvement and enforcement of laws and rules. Areas for improvement included linkage to health services, which if you have an access problem countywide or community-wide, you could see where that would be a barrier, even if you did have adequate staff to be able to make those linkages. Health education and health promotion, I think in the day and age with media influx, mixed messages, a million different organizations trying to get their information out, it's hard to kind of rein all of that in and focus on one really hard message. And then evaluation of population health, personal health, and the local public health system status, so in and of itself. I'm not going to run through all of these, but they did do forces of change, and so what these are really looking at is the influential factors for when a local public health system, so beyond just the local public health authority of Health and Human Services, I'm looking at that whole system and all the partners involved and how they might address these health disparities. And so these were some of the areas that you might not jump out if you were looking at secondary data all day. These are some of the more, okay, well, we've lived in this community a long time, we've seen these types of shifts, and just as an example here, pointing out number 2, number 7, and 14 and 15, and looking at kind of a transition from Carson City demographically being more of a middle-aged population, and now you see an influx with the development and uptick of new employment opportunities within that USA Parkway. You start seeing a transition demographically in terms of age to the more 30 and 40 year old with families. And so some of that coming in those generational influences, and not just how generations absorb information, but your messaging to communicate with them, and then intergenerationally on the work site as well. So a lot of different dynamic factors at play there, but just as an example of how those forces of change could be interrelated. And then in terms of community assets, this slide mostly points out infrastructure. So looking at the hospitals, and the community health centers as physical locations where people can access care. But we also see a lot of mental and behavioral health care providers, not just with the Regional Behavioral Health Policy Board that was established, but also Carson City has a behavioral health task force that was established within their own jurisdiction as well, and the Mallory Crisis Center being recently opened. So there is a lot of, I think, kind of on the tail end of the last assessment and just what we are seeing locally and statewide, there's a lot of reinforcing positive momentum in the right direction as far as mental and behavioral health are concerned. Alternative healthcare providers and the Parks and Rec. So Carson City is poised nicely, obviously, to engage in physical activity in the mountains, and they are now adopting a lot of complete street and active transport bike and path trails within their systems. They have a really active Parks and Rec department there as well. So those are some of the tangible assets within that community. And then just briefly touching on the state and local performance rankings. So although Commonwealth Fund Scorecard ranks at a statewide level, it does also reinforce those same areas of needs for improvement, really looking at that access and accessing prevention and treatment. And then fortunately for me, I didn't have to make any alterations to the slide. I cheated and I checked county health rankings last night at about 10 o'clock. Those haven't changed for the Robert Wood Johnson Foundation. So that's both for 2017 as well, holds true still for 2018 rankings. And so all of those assessment pieces and those ways of measuring what is going on in the community kind of brought forth these similar themes, and they're not listed in any particular order, but you can see kind of the line list there. And the two that I did want to kind of speak to a little bit is that public health infrastructure and workforce development versus the general education and the community workforce development. So when we're talking about the public health infrastructure and workforce development, we're looking at both current and future public health employees or people who are going into public health as a profession and being able to get them the tools that they need today to succeed in their job, as well as the infrastructure to practice and carry out their job. And then when we're talking about the general education and community workforce development, we're talking about educational attainment, high school graduation as a starting point, but also in that shift of looking at these new occupations that are opening up in that USA Parkway in particular, again, as an example, and making sure that high school graduates, if they're not going to go on to a traditional four-year college, that they have a place to obtain further skills needed to make themselves highly competitive in the workforces. And then we are still in our infancy stages for our community health improvement plan. We've had work group members, many of you are here in the audience, so thank you for coming again today. But we have been meeting over the last 2 months, and we just recently were able to do kind of a live poll selection of priorities. And in my work in the region, in Northern Nevada, it's not a surprise to me that the top three are similar top three to many other areas. So if you'll see the top one there at the 8.6, behavioral health, again, no surprise. Number 2 being access to health care, and then number 3, housing and cost of living. So although the mechanisms for measuring and determining priorities through different community health needs assessments have been vastly different across the board, we're still ending in the same identified needs and priorities. So that's both a even though we did it all differently, we're still ending in the same spot. And so with, very preliminary, just touching on the community health improvement plan for Carson City Health and Human Services and Carson City's community, there was discussions that the behavioral health, because of so many recent boards and policy maneuvers around the behavioral health, that if the CHIP were to focus on that, it could be duplicative in its efforts and almost deter or distract from the efforts that are already ongoing. One of the Carson City Behavioral Health Task Force has in and of itself 7 subcommittees, one of which is housing, a second one is transitional housing. So that already also took care of kind of the number 3 issue with that 7.6 of housing and cost of living as well. So again, still focusing on where we're going to drill down to, but it looks like access to healthcare is definitely going to be one of those, and obviously that will have some overlap with the mental health and accessing mental health providers, and then nutrition and food security as we move down that list, and then rolling up kind of the public health workforce with that general community workforce into one, because it was kind of easy 2 birds, 1 stone plan of attack, if you will. So I'd be happy to answer any questions that I can, or if Nikki wants to discuss anything further.
One thing I just wanted to note, we have the Behavioral Health Task Force in Carson City, and our coordinator is here with us today, Jessica Flood. That the way that that task force was set up was with the Community Health Improvement Plan in mind. So setting it up with objectives with each subcommittee that will roll into the task force itself, and then can roll into the Community Health Improvement Plan. So thank you to Jessica for all her hard work on that task force. Yes. It can be all of the above. And transportation is a piece of it. Looks like there's no more questions. Okay, so our next speaker is Katrina Peters, and she is the Director of Programs and Projects at Washoe County Health District.
Good morning, everyone. I'm Katrina Peters, Director of Programs and Projects with the Washoe County Health District, and this morning I'm going to give a brief overview of our progress in our community health needs assessments and improvement plans. We'll see if I can get this clicker to... All right. So first, I really just wanted to talk about briefly some of the steps in both the planning and the needs assessment and planning process. So the first step is to assess the needs of the community. And that typically utilizes both primary and secondary data. And once that needs assessment is complete, then the work begins to determine the priorities and engage the community in how to go about some of that work. Once those decisions have been made, then typically that information, those priorities and both the strategies to work on those priorities are folded into a plan, typically referred to as a community health improvement plan. And we call that a CHIP for short. So this morning I'll be referring to it as our CHIP. And all three of these steps are pretty challenging process. Engaging the community and focusing on priorities can be a challenge, but definitely a worthy endeavor. And for Washoe County, our first needs assessment was published in January of 2015, and then we published our first corresponding CHIP in January of 2016. Around this time last year, the Health District published a report that covered the accomplishments of the CHIP in calendar year 2016. And in a similar fashion, we've just finished a report that describes the progress made in 2017. And there's definitely some great accomplishments to celebrate there. And we also encountered some really valuable learning lessons. That document will be posted on our website pending approval of our District Board of Health. So I really want to encourage folks, once that's published, to go look at the full document. I'm going to give some highlights, but there's really some great information in there. For those of you not super familiar with the initial document, the 2016-18 CHIP included 4 main priority areas, the first of which was access to healthcare and social services. The second was behavioral health, and that combines that mental health and substance use together under behavioral health. The third was education, and that was mostly focused on that K through 12 environment. And the last was food security. And in that document, you'll see that there were specific goals, objectives, and strategies outlined under each focus area. So before I highlight some of the achievements, first I really wanted to thank our community partners, not only for the outstanding work they do in the community, but also sharing with us their data and the information on all the successes of their program. We really see this as a great opportunity to highlight those successes and put that positive light on the work they do. So to kind of talk about highlights under each focus area, the first, access to healthcare and social services. There was a committee that came together and put on a RAM event, Remote Area Medical, and that was done the last weekend in September, and it provided services to just under 500 people. Those were medical, dental, and vision. Some folks who participated were able to get more than one service, so it was a really great benefit to our community. There were also 3 family health festivals that were put on in low-income communities to connect folks to those health resources that are available. We got a lot of positive feedback on those events. I'd also really like to mention our federally qualified health centers. So that's Community Health Alliance and Hopes in Northern Nevada. They do a tremendous job offering services to the community, and you can see a good accounting of the number of services they provide and the patients they see in that full document. This year, we also saw some improvements in educational attainment. So our graduation rate increased by 7%, which is exciting. We also saw some community nonprofits do some really outstanding work, like communities and schools that are out there nested in the school, providing students with those wraparound services and helping those kids that are really struggling. So big kudos to them. In the food security area, we also saw some great programs implemented, and food security is something where we're seeing those food security rates improve and get better, but there's still quite a bit of need in the community, and we have not returned to those pre-recession food insecurity rates. One of those programs is Prescription Pantry, which is also another great example of a really collaborative effort. Renown, our 2 federally qualified health centers, Hopes and Community Health Alliance, work together with Food Bank of Northern Nevada and Urban Roots to not only get folks access to food, but get folks access to healthy food, which is pretty exciting. And finally, I think everybody in this room would agree that to continue this momentum, it will really take all of us working together as partners and focusing on those priorities and how we can work to continue to improve the health of the community. So I really want to emphasize how critical it is that we work together to continue this progress. Ooh. Thank you. I also wanted to just briefly touch on our challenges and learning lessons, because I think there's a lot of value in sharing that. One of those was really around the data. So when we think about writing objectives, and there's over 60 in that initial chip, in order to measure progress, ideally you'd have a data source to be able to measure your target against. And in some cases, we identified a target and a data source to compare our progress, but that data may not necessarily have been published annually, and it may not have been published at a time point that corresponded well with publishing an annual report. So we had a little bit of a learning lesson there. And finally, many objectives make for a big undertaking. So thinking about trying to move the dial on over 60 objectives, that's a lot of weight to lift. So definitely a learning lesson there, and staying focused and thinking about what resources we have available to really do some of that work. All right, so with our 2017 annual report and sort of wrapping up that initial 2016-2018 CHIP, we're embarking on a new cycle. And the first step in that cycle, of course, is that needs assessment. And in partnership with Renown, right at the first of this year, we published our community health needs assessment. And Heather Kerwin here was our primary author, and she really did an outstanding job with that document. So if you haven't had a chance to look at it, really want to encourage you to take a look. That document will guide the development of our upcoming CHIP, and that'll be done through Truckee Meadows Healthy Communities, a local nonprofit. And I really want to encourage folks to use this as a resource for data. So for those of you who are preparing proposals or grants, this is a great one-stop shop for data. There's also a state and a national benchmark when that's possible. So this is a really great place to see that data all in one place. And I've provided our URL so you can catch that on the web. Thinking about the purposes and outcomes of that needs assessment, as Heather mentioned before, the needs assessment really identifies the needs in a geographically defined area. So for us, that's Washoe County. It also identifies assets, strengths, and opportunities for improvement in the community, and really can play a great role in informing community decision makers and leaders. So as I said, we'll be using that to develop the CHIP, and that'll be done through Truckee Meadows Healthy Communities. As I said, this is a really comprehensive document, and while you probably won't have an opportunity to read through all these, please take me at my word that those 250 health indicators included in that document really cuts across a wide swath. So there are items in there on socioeconomic data, so things like employment, poverty, access to healthcare, to that behavioral health that's a really hot topic right now, so that substance use and mental health, It also includes data on immunizations and communicable diseases. So a real one-stop shop for a lot of data. And for those of you in the room who do come from a public health background, you're probably familiar with this graphic when we're thinking about those secondary sources and that data being a really objective means at looking at the needs of the community, and also trying to overlay that with the primary data, which is a great opportunity for the community to tell us what's important. We really want to look at that sweet spot in the middle as the best opportunity to impact positive change. So we're really focused on where those two circles overlap. And in line with that, I'd like to kind of share the priorities. And again, these are included in that document in the needs assessment in that third section. So this first bar chart is really just looking at that secondary data, so those statistics as they're often referred to. And while this slide's a bit hard to read, it is available on the web. The first item identified was mental health, followed by physical activity and nutrition. Chronic diseases third, followed by substance use, crime and violent related behaviors, and access to health, rounding out the top 5. When we look at that primary data, so this is from our online community survey, we got a little over 1,400 responses to that. The first item is access to health, second to environmental health, social determinants, crime, and mental health, rounding out the top 5. It is worthy to note that that environmental health at number 2 was not quite exactly what I expected. This online survey was done over the summer. We had a lot of issues with wildfires and concerns over air quality, so that may have had a bit of an impact on environmental health scoring number 2. And when we look at the two together, so Heather applied a great methodology that ranked the severity of need, and that took into account a couple factors. The first is severity of need. It also looked at the percentage of population affected and a comparison to state and national benchmarks. So areas where we're doing worse than state and national benchmarks would be ranked higher. Areas where a larger percentage of the population are affected would also get ranked higher. And we see here the top item, access to health. Second to that is mental health, social determinants, crime and violent related behaviors, nutrition and physical activity, and chronic disease, kind of rounding out the top 5. Amongst those that are the top 7, which are the items in red, they pretty consistently stay in the top 7 across both the secondary and primary data. So we've really looked at those as some top priorities. You'll also notice that there's not a lot of difference between the topics, which says that amongst those top items, there's not a tremendous difference in the need between those topics, which says a lot about our community having a lot of health needs. Finally, to talk about our next steps moving forward, we have a great objective means of determining those priorities, and that's very helpful, but it also includes an incredibly wide breadth of topics for us to try to do some work around. So in an effort to focus those areas, Truckee Meadows Healthy Communities has been able to meet and have some conversations to determine what priorities to focus on. And that work is really just getting started, but the 3 priorities that have been identified so far are housing, which is, of course, a very hot topic right now, behavioral health, so that includes that mental health and substance use, and then the third is nutrition and physical activity. And as I said, this work is really just beginning, so if you're interested in participating in figuring out strategies on any of those, please connect with me. We would love to involve you in that and get your input. And with that, I'll take any questions. All right. I think next we have Julia Peak, who's with the state of Nevada, and I will hand it off to her.
While my slides are loading, I'll just say something really fast. Interim Health gets a public health session. It's going to be April 24th. Yes. Most of us will be in Las Vegas for that, but we're at the beginning of the meeting, so if there was any opportunity that you wanted to attend and make public comment on anything related to public health, that would be a great opportunity to get your words on paper. And also with accreditation, I don't have it included in here, but we are at the state going to start accreditation this next fiscal year. So there'll be more to report on that going forward. It's quite a beast to undertake, as you've heard so far. So I wanted to talk a little bit today, when we were planning the agenda, most of the time at the county health rankings and other conferences, I love data. So I just present a ton of information about data. Valerie's smiling because she loves data as well. So you get a lot of data. And like you heard earlier, we have a ton of data. One of the challenges for us is making it actionable. And how can we get it in your hands so that you can make it actionable other than just presenting a lot of information? So I'm going to focus my talk today on how you make that information actionable to actually have change as a result. So these are great slides that NACCHO put together that I just wanted to speak to briefly. A lot of what the state does in our role is to educate on a certain topic, really nonpartisan in our communication. So you'll often see us go to the table and say that we're neutral on something. Even if it's good public policy, we're neutral on it. And so for us, that's really our role. We'll go and present data, not too exciting, but really factual. What we want to do is get that into your hands so that you can go, depending on your organization, and advocate or lobby. And there's some examples that NACCHO put together on that I think are really powerful, and there's a document that I provided the link to below that gets more into this information. Another thing that you can think about is you really need to look at what your agency allows, but the way you word what you're providing. You should pass X bill. That is really lobbying. So if your agency doesn't do that, you really need to understand how you can talk. The example up here is Zika. How you can talk about Zika and the risks that this could represent for that legislator's area, to Nevada as a whole. So those are things you might consider in rewording it. Also, for us, we've started really to have a social media presence, and so a lot of what we're putting out is just facts. If we see something come up in the news or nationally, we can put out some local statistics, and then hopefully, if you follow us or whatever, I'm not a social media person, but if you like us or Facebook us, whatever, then you could take that information and then you can go talk about it in a public setting that's appropriate for your agency. So we hope to really feed that information out to you all. So can you lobby? I provided several resources here, a link to the LCB website, and it speaks to some of the rules as far as lobbying. If you are a lobbyist, you have to register, and there's information about that. Nonprofits, depending on your status, you may or may not be able to lobby. So really good to double check before you go and do that. Or again, reframe your message so that it's not necessarily lobbying, you're advocating on a certain topic. And also, I listed here, Washoe County had actually done a policy for their staff. And we had, for those of you who've been here for a number of years, a really great advocate and lobbyist, Jennifer Stoll-Hedaya, who's no longer here, but many of us who've been here a while learned from her for public health, how you go up and educate and testify. Really, really powerful and a champion for public health, and I know several of you have done the same thing. But Washoe County was really a leader, and I learned a lot from them when I was first starting. Okay, so what should you be doing now? We are a biennial legislature, so it feels like that there's a long delay, but for those of us who work in session, it's not. Right now, like you end the session and we're already thinking, okay, what passed, what didn't, how do we implement, do we try again next session? What's the landscape politically? Is it worth trying? For the state, we have bills that we could put forward. If that's not going to happen, very difficult now because we don't know who the governor will be. So there's other opportunities you could look at. A lot of research, I would say, needs to be done prior to going to any legislator or to the state to say we really think this bill should be heard. So some of the things that I love doing, our legislative website is actually very great and has a ton of information. So I just provided an example up there. I searched for the word regional because there's been a lot of discussion about regionalizing public health, behavioral health services, and other things. So you could see right there, it automatically highlights all the bills that say regional, and then you could click in those and understand better what that bill included. Let's say the bill passed, you can understand implementation, and we often say we go back a few sessions and do incremental policy change. We weren't ready for that huge policy change yet, so in Nevada we're gonna go every 2 years and kind of chip at that block. So did you like the bill? Was it passed? Who was in opposition? Who was in support? What if we took it a little bit further and did a new bill? So really understand that. Also, fiscal notes are listed in Nellis on the website. Go and look and see if an agency put in a fiscal note. We had a training this morning from Legislative Council Bureau staff, and they said these last few sessions, they've never seen so many unsolicited fiscal notes. So understand who provided an unsolicited fiscal note. For example, we passed a bill this last session, AB 474, related to opioids. And the small section in there that applied to really the health districts and us, it had overdoses becoming reportable. And initially, it went to the local health departments, and they got on a call and said, no, this is such a huge workload, we can't have this. So several of the health districts put in a fiscal note for the bill. And what we did when we looked at it further, it was really overdoses can be reported to the state for action and then reported out to the locals. So they were able to remove their fiscal notes from that bill. It was able to move forward. But a fiscal note can truly kill a bill. So really important to understand who might be putting in fiscal notes. Okay, so let's say there wasn't a bill on the topic or it doesn't align with what you wanted to do. What should you be doing now? For example, for us at the state, we are getting in our non-budgetary BDRs by next week. So if we don't know about it, it's really late. Probably to come to us and say that here's a policy bill we would really like DHHS to champion. I could tell you off the bat, I have about 7 that stakeholders have already come to me that we're looking at related to public health. So we're going to write those up and provide them to our administration and see if they want to champion that going forward. So those are the executive bills. It goes from the division, feeds up to the department. We have a certain number, and then all the departments put theirs together for the governor's office, and then that person decides what they're going to push forward or not. So some of the bills we might say we would love at the agency to support that and put it forward, but it just might, as it funnels up, might not be one that gets passed. So it's really important to use the other opportunities you have to get a bill in. And so I've highlighted a few, but I want to speak to individual legislators a little bit more. But interim committees have been a wonderful option, and as I said, April 24th would be a great opportunity. If you have a specific topic related to public health, even if it's not agendized, you can certainly speak during public comments. Also, local government does get BDR, so that's another opportunity for you to reach out. But let's talk about individual legislators, because they also have an opportunity to put bills forward and are very strong in championing those bills. Okay, so how do you approach this? So which legislators should you talk to? Sometimes which committees are they on? If you know your bill is going to hit a health committee or a money committee or an education committee, talk to the people on that committee. That makes it much easier when the bill's presented if you've already made those connections and educated on the topic. A fiscal impact, then it's going to probably go to a money committee. So who's on the money committee and who should you talk to? Also, a personal interest. In Nevada, we have a civilian legislature, so all these folks have jobs outside of being a legislator. So we've had great success in the past looking at their occupation. Are they a teacher? Are they a social worker? Are they a medical doctor? That's been really, really great for us in the past if they topically know the area really well. Also, if they've had similar bills in the past themselves, if they co-sponsored a bill, or depending on how they voted on a topic in previous years, just look at that and understand better. So when you go and you're really educated on the topic. Now, my favorite is the data. So what we would like you all to know is what resources you have available to you. We have been putting out, this last session, we put out district health profiles. And what we did is we took many indicators that we thought might be of interest, and we did geomapping and provided the information at the senator or assembly person's district level. Provided an example here, but you can see pretty easy to follow, and the reds are the topics that perhaps you would want to draw attention to if you were talking to a specific legislator. Another thing that we're going to do this coming session is rank those, so that if you say, I really need to talk to a legislator about Medicaid and newly eligibles and the implications if newly eligibles, for example, were removed from Medicaid. You can look here and see which district has the greatest number of newly eligible, and perhaps go talk to that legislator and just say, might not have been on your radar, but I really want you to know this would impact your district the most. Just so they understand, again, they get a ton of information during session. So you can do this in the interim or during session if you needed to. You could be very targeted at how you approach this. Ton of data that we talked about. We are happy to help in whatever capacity you need. We have the ability now at DHHS, because we've centralized all our analytics staff, we could talk across agencies. So if you wanted to know Medicaid data or CPS data or public health data or mental health data, we can take an individual across all those systems and match them and really tell the story much better than we've been able to in the past. We've also had great success in working with our law enforcement partners, and we'll soon be getting access to the criminal history repository, which is all arrests in the state. And so for specifically our mental health population, but also to look at how our juvenile justice population is going throughout their life more longitudinally, we can now match juvenile justice data with health data, with soon arrest data, et cetera, so that you could tell that story of what's occurring for that individual over time. So please ask. As a result of centralizing, we now have a single email address. Just type out your dream list. An analyst will get back to you and figure out how we could get that to you. Lastly, show up at legislature. Often it's going to be a lot of bureaucrats like me and then lobbyists. And I would say that though we might have interest in the topic and know the topic well, I cannot tell you how impactful it is when somebody from the community who's not being paid to be there goes up and speaks on a specific topic. Even if locally this is part of your job to care about the topic, go and show up. I've been at hearings before, AB 474, like I talked about with the opioid bill, when they said, if you want to speak in support, stand up, and literally the line was like out the door. And it was like, okay, the legislators visually could see. If they had issues, maybe they won't bring them up because they could see that there's so much support. One that I would say probably was the most impactful for me, we were at a session and the two bills being heard, one was related to abortion and one was related to transgender in the schools and being able for that individual to choose the bathroom that was appropriate for them. And that was, you could hear a pin drop. The room was packed, we had an overflow room, and both sides, regardless of where you stand on the topic, wow. So I put a picture up of a couple high schoolers on both sides that spoke to the topic. And we had ACLU there, lawyers, policymakers, again, great topically. But when these two talked, the whole audience listened. So I'd say that's very, very, very important. So if there's a topic you like, who is best in your community to champion that? Who has no other interest than truly it impacts them in their life? So that's a great one. You can also go back and watch hearings, which is awesome on the legislative website to see what occurred. This is one I went back and watched to prep for this presentation, but really, really powerful. So Sandy's presenting in the South, and I'm presenting here. So if you have any questions about this or data needs or want to talk about maybe BDRs and thoughts on how the division would stand on those, I'm very happy to have those conversations with you. Any questions? So I'm very lucky that you have two Julias on your agenda right in a row. So Senator Julia Reddy is next. No slides, you just gotta go.
Yeah.
Oh.
No slides, just me. I don't get to follow another Julia very often, so thank you. And how about a quick round of applause for all of the amazing presenters and all the information. I know that I'm the speaker standing between you and lunch. It seems like that's a big part of how I spend my life, is standing between people in their cocktail hour or their meal. But I did want to make a few comments. This is an important topic for me. When I was on the Sparks City Council for 8 years, I did have the privilege of being the city's representative on the Board of Health. And I'm not just saying this because this is where I am. It really was my favorite part of being an elected member of our community. And what I'm really thrilled about here today is that when I think about that, it was 10 years ago that I started in that position, and sort of the quality and the sophistication of the community planning that we did at that time to be honest, just wasn't very high. And if you look at how far it's come, it's really impressive. And so I want to thank everybody in the room who I know has put a significant amount of effort. I know this is not just the health district. I know this is not just the state. I know this is a literally an army of nonprofit providers, hospitals, our other partners who've been working on making sure that we have good data, which that is really exciting, good assessments, and good planning. And I like what was said about, wow, we learned that having 60 different things to work on may not be the best way to go, because we're building muscle when it comes to planning. And so I love that we're thinking critically about it and how do we get better at it and how do we make a difference in that way. I'm here today to talk to you a little bit about what's happening in the legislature. Thank you, Julia, for kind of going over how people can participate. We did have some good successes in the 2017 legislative session. Some that I'm particularly proud of, many that had broad bipartisan support. And so I'm just going to highlight a few of those for you. I think that whenever we're looking at the rankings for how we're doing in the state of Nevada, it can be a little depressing. Just admit it, right? And I know many people in this room have been working on these issues for many, many years. So maybe I can bring just a little bit of light and a few things that we accomplished in the last session that I believe deeply will make a difference. So one of the things is AB 366, which was championed by my colleague from the South, Assemblyman Nelson Araujo. This was to create the regional mental health boards. And while creating another committee sometimes doesn't feel like it's going to be the most powerful thing, I really do believe deeply that having the needs around behavioral health coming up to the state from the regional levels, because in many ways they are distinct. And sometimes we do these big broad categories, but to really hear from each of the regions, and they got a bill draft, which doesn't happen very often, that we empower local communities to have, to bring their own bill and not have to go through somebody else. And so I think that there's the potential there for some really important things to happen. So I'm excited about that and excited to be the lucky legislator from Washoe County who gets to sit on the Washoe County Board. Another piece along the lines of behavioral health is that due to my colleague from the South, Senator Cannizzaro, we were able to add to the most teams. And these are so critical, again, going back to my time on the Sparks City Council, where you had law enforcement making a good effort to try to manage and cope with where mental health intersected with law enforcement, but really do not have the training, do not have the skill set, do not have the background, and have so many other competing priorities. And so to have our most teams out on the street, to get a social worker really involved, we know that we improve outcomes for people. And so really want to be grateful to everybody in the room who's worked on that, and thankful to the legislature, because that was one that had a fiscal note, as was noted. And yes, fiscal notes kill bills, because we don't like to spend money sometimes, but there's an area where the state really did invest to make sure that we have more resources at the local level. So very excited about that bill. Lots of conversation. The social determinants of health is a really big issue, and we know it's housing. It's housing, it's housing, it's housing. I don't know how much more strongly we can say that we have a housing crisis across the state, really, but in northern Nevada, it is accelerating at a pace that is causing some true pain and suffering that we just haven't experienced as a region before. I am chairing an interim committee on affordable housing, and we are looking for a few nuggets of things that can be done at the state level to drive housing. But I do want to bring your attention to, there's probably 5 different coalitions now working on housing at the local level. And I encourage you to stay involved with those. We have the Truckee Meadow Regional Planning Agency working with a nonprofit entity, and they have brought in a national level consultant known as Enterprise. They're really working on how do we do some of those solutions here in Washoe County. And so while we're doing some good work, I think we'll get a couple of really good things at the state level. Out of this interim committee, we do have 5 BDRs. It's important that the local solutions happen as well. This is an area where it's really going to take the work across sectors of state, local, private to get to solutions, and something we all need to be working on. We're focused, we just spent all day, and if you spent all day with us yesterday, I know there are a couple of you in the room. I know Sheila's there, and I think Jessica, a couple other folks. Raise your hand if you spent all day talking affordable housing with me yesterday. There they are. Thank you for doing that. And what we focused on yesterday was the universe of supported housing. And so those spaces where we need both a roof over the head, but we also need case management, we need supported services. And I think we're digging deeply into the concept of a Medicaid waiver that would really look at housing as healthcare, and how could we get to a place where perhaps we could get to billing for services to create a funding stream for housing. And so that would make a big difference if we can get there. And thank you to the Department of Health and Human Services at the state level for their work on that issue. Let's see, what else? Access to healthcare. I had a lot of fun in the last legislative session working on access to healthcare issues. If you can remember what was going on in our not only our state, but our nation at that time. As we went into the legislative session, there was lots of conversation about whether we would be losing the Affordable Care Act at that time. And as you know, in the state of Nevada, that Affordable Care, the expansion to add up to 300,000 people to have access to insurance is a really big deal. And, you know, I was in the room 15 years ago when we were working with the Covering Kids Coalition, and we were trying to figure out how to improve those numbers. And Nevada was not just 50th in the nation when it came to access to health care and those who were insured, but we were double below the 49th rank. I mean, we were in such a dismal state and space when it comes to the number of people who had access to insurance. And so regardless of sort of your political philosophies, when it comes to the state of Nevada, the number of people who need insurance and the expansion, the Medicaid expansion and what is accomplished for our state is truly phenomenal. And yes, there is a lot of work to be done, and no, it's not perfect, but we really need to figure out those issues. So one of the things that I was able to champion as a state legislator was SB 233. One of the things that people don't talk about a lot in terms of the Affordable Care Act is, if you'll remember the days before the Affordable Care Act and what happened in terms of women's health parity. And so in many cases, and this was the joke, right, you would have insurance companies that were covering something along the lines of Viagra, but not covering birth control. And that was just one, you know, that's the funniest example probably, but there were many, many other examples where the kinds of services that were covered for men were much more robust than the kinds of services that were important to women. And so we were able, in the last legislative session, to get everything that was in the Affordable Care Act in terms of preventive services for women as an insurance mandate into Nevada state law. So what that means is that even if the Affordable Care Act is repealed in the state of Nevada, you will still see low-cost or no-cost mammograms. You'll still see access to contraceptives. You'll still see something that I'm more interested in these days, hormone replacement therapy. It's interesting how our interest in different women's health issues evolves over the course of our lifetime, right? But certainly that was a big win for Nevada. In addition to that bill, we were looking also at, or what we were able to get was what's known as 12-month dispensing. And I know many of you work with low-income populations, you work with populations that have challenges accessing transportation or other barriers that make their access to healthcare even more challenging. And so what 12-month dispensing is for contraception is that an insurance company can't just say, well, I'm only going to give you 1 month at a time, and then that young woman needs to get to the pharmacy every single month to pick up their prescription, and we know what happens. You're a few days late, you miss a few pills, and guess what? You all know what happens, right? Okay. Just make sure you're still awake. And so what we have now, it was a compromise solution, but what we have now is that if it's a new prescription to you, then you get a 3-month supply. That makes sense in order to make sure that that prescription is going to work for you between your doctor and your patient. And then after that, you can get the remaining of your health plan year. So if there's 7 months left on your health plan year, you can get that 7 months at once. And then the next year, if you stay on that plan, so same plan, same drug, you can get 12 months at a time. And it's silly, but again, if you look at the data, and the data is really powerful on this one, that 12-month dispensing prevents a lot of unwanted pregnancies. And we know that that's a big deal for a lot of the clients that we serve. I think the last thing, because I don't want to talk forever, there were lots of other things that were powerful during the last legislative session, but I think the last thing that I want to talk about, because I do think that it's an opportunity for some work to be done right now, is the passage of recreational marijuana. certainly creates some public health questions for us across the state. And I will say that the legislature did not do its job in terms of making sure that some of those public health impacts were addressed. It's very rare in state government that there's new money, like almost never, that we get new sources of revenue. And so there is an opportunity at this point in time. There was a wholesale tax that was passed when the question was passed on marijuana, and 100% of that money by law goes to the distributive school account, because that's how it was presented to the voters. But where people get confused, and in some ways, there are some people out there who are purposefully misleading folks, there was an additional tax that was an additional 10% on retail. So you can kind of think of it like a sales tax. It's called an excise tax. So that additional 10% on recreational marijuana is not allocated at this point. So in the first 2 years, it went to the rainy day fund, which while we have many needs, and it may seem kind of strange that we're setting that money aside, I actually think that wasn't a bad idea, in that we had no idea what the revenue streams were going to look like, and it's a little bit nerve-wracking sometimes to build programs on a revenue stream that you really have no idea how much it's going to be. The other good news is I think it created an opportunity for us, because if 100% of that money had gone into schools, and please understand, I get that our schools need a lot of money, but I also believe that public health and social services are equally important. And if you don't have kids who are ready to learn, you can put a lot more money in the school district. So I think there's an opportunity. Well, in the next legislative session, that 10% will be up for grabs, if you will. It's going to be a gold rush, I can tell you. People are coming at us already saying, I want that money for, I think we should use marijuana money and just fill in the blank. But I think if the public health community could rally together and bring forward, and I know many of you did some of this work in the last legislative session, and I know that it was ignored. So I hear you that you could be frustrated by this, but this is the legislative process. We go back and we try again. And in this case, Julia did a really nice job of outlining the legislative process, but in this case, the victory, I believe, will be won or lost based on whether or not it comes out in the governor's budget. Because that's how it really works at the legislative session for the money pieces. The governor puts together his budget, working with all of his department heads, brings forward that budget to the legislature, and in most sessions, we don't change that budget except for around the edges, maybe 3 to 5%. And so for those of you who have working relationships with the governor's office, and even if you don't, I think now is the time to be talking to the governor's office about getting a portion of the revenue from the retail revenue dedicated to the public health impacts of substance use. It's a good, strong nexus. I think if it comes off as a gold rush and everybody's just going down there saying, I think we should use the marijuana money for my pet project, and I know all of your pet projects are really important, it will be less effective because we'll just be played off against each other. But if the public health community can coalesce around a series of ideas about what that money should be used for, that will have a better chance of being successful. So again, we need to be putting more resources into the schools, there's no question, but we also need to be putting more resources into public health. And right now, at this time, we know that there are public health impacts from recreational marijuana. We know that there are public health impacts from other substance use, and this is an opportunity, I think, to make some progress on that. So I would encourage you to think about that now. I do have, I'm almost afraid to say this out loud, but each legislator does have 22, if you're a senator, you have 22 bill drafts. If you are an assembly person, you have 12, just to give you a sense of the timing on that. The first half of our bill drafts, so for me, 10 bill drafts are due in August. Another 10 are due in December. And then I have 2 in February. Those are typically that's the first week of the session, and they're typically reserved for if anything came up after the deadlines that really needs to be addressed. And so I'm always looking for good policy ideas and good partners. I can tell you, as one individual trying to carry 22 bills, it's not possible. So what's important to me when you come to me and say, will you carry my bill draft, is how much work you're going to put into helping me get it through the session. Just being completely frank, because that's the reality of our citizen legislature, 120 days where we're locked in the building and try to squirt out at the other end the best policy that we can possibly get. So please do feel free to come and talk to me. I am happy to answer any questions you might have. And I am standing between you and lunch. Not a one, huh? Okay.
this grant to do something totally different. That's just not possible, but where you do see general fund, do you have an idea of how we could save money, do something a little differently? A letter explaining that is really helpful. And then we have been told that we can potentially write, new additions in and they'll be considered, but basically our budget overall will be cut. These, those letters are hugely helpful, and you can write them for administrator or director or whomever, and we'll be able to use that to build our.
Great, thank you, Julia. And I just saw that Sharon Zadra is here, and I just want to point out that Sharon Zadra is the staff lead on the regional work that's happening on affordable housing here in Washoe County. So if you're interested in getting involved in the, I'm throwing you under the bus too, Sharon. If you're interested in getting involved, Sharon is here. If you just raise your hand, go talk to Sharon. Other questions? Okay, well, bringing up Dr. Peckham, thank you. And thank you for your work on all the public health around marijuana.
Thank you. Want to give another hand to our speakers. Thank you very much. And just close by thanking Kevin, Dick, Laura, and those of you at the Health District here for hosting us. This is, I think, a great location. Parking was a little nutty this morning, but the location is still great. I would be remiss if I didn't close by just mentioning one last thing, and that is the great work going on at the county level. We've talked about a lot at the state level and so forth, and I just wanted to give a shout out to all of those counties, Churchill, Lyon, Douglas, White Pine, and others that have begun to ramp up the work of their local boards of health, waiting on the state, waiting on the federal government, waiting on others to address your health problems, I think has created a well of frustration that's resulted in county commissioners taking on health issues, public health issues. That's been some of the most encouraging and rewarding work that I've been engaged in since I've been in Nevada. For example, Lyon County is a top 10 finalist for a National Culture of Health Award. Awesome stuff to finally see a Nevada county make that list, and we're pulling for you in that area. Last comment is just that just as I've said, there's plenty of data out there. There is also a wealth of best practices. The current administration doesn't use the term evidence-based practices in public health anymore, but there are scientifically supported best practices in health, and this is just one of many documents that the Robert Wood Johnson Foundation has made available on their website. There's plenty more after that. Final word is there's no such thing as a free lunch, but there is a foundation-sponsored lunch outside at no cost to you. Let's continue the conversation. Thank you.